on another. Let's go live.
Okay, sir. Okay, so on my count, 3, 2, 1. Please start, sir. We are live.
Good day, everyone, and welcome to this Spectrum webinar series. So, as you can see, this is the first webinar of the Spectrum series, and Spectrum, we have come up very interesting acronym. Spectrum stands for Shifting Paradigms and Evolving Concepts towards Raising Understanding of Mental Health and Mental Disorders. Today is the first global webinar, and the very idea behind conceptualizing Spectrum was to share best practices, evidence-based information, and also expert opinion on various mental health disorders to a larger audience. And therefore, the logo also reflects this. As you can see, the logo of Spectrum is in a multitude of colors of a spectrum, just like a spectrum which is coming out of a prism. And these colors reflect not only the varied mental health issues that are present in the society, but also within the same disorder, this logo also tries to reflect that no two patients are the same. Even if you have a patient with bipolar disorder, both of them will have different personas, different profiles, and they will be treated differently. So that's the basic idea, to share best practices in the management of mental health disorders. Also, to bring in expert opinion from different parts of the world. And for this, today we have two very eminent resource persons. We have Dr. Amrit Pattojoshi from India as a speaker for today's webinar, and he will deliberate on the differential diagnosis of unipolar versus bipolar disorders. And to react to this talk and share his expert views from Sri Lanka, we have Dr. Samira Ruwanpriya, who will share his opinion and the perspectives from Sri Lanka. Let me take a moment to introduce our resource persons to the audience. So, ladies and gentlemen, Dr. Amrit Pattojoshi, our speaker for today, is a consultant psychiatrist at High Tech Medical College and Hospital, Bhubaneswar, which is in the eastern part of India. Is also the General Secretary of the Indian Psychiatric Society, a Joint Secretary of the SARC Psychiatry Federation, and recipient of the Mother Teresa Award in 2016 for his significant contribution towards psychiatry and mental health. For those of you who are fans of TED Talks, you will also find him on that platform. And I highly recommend you to watch his two very interesting talks on the TEDx platform. Joining Dr. Amrit Pattojoshi as a panelist, we have Dr. Samira Ruwanpriya from Sri Lanka. He's a consultant psychiatrist from General Hospital Monaragala and a senior lecturer in psychiatry at the Faculty of Medicine, University of Colombo, Sri Lanka. Sirs, it's a pleasure to host you for this webinar today. And with that, let me not stand between this very interesting topic, differential diagnosis of unipolar versus bipolar depression. Over to you, Professor Pattojoshi.
Thank you so much. And thank you for giving me a chance to speak on a topic I actually love to speak on. I'm a professor in a medical college, and this is one of the most important things which people need to understand, because most of the presentation of bipolarity or unipolarity is in form of depression. How to differentiate? That's what helps. The sixth sense in a clinician. And the sixth sense is not something that you are born with. The sixth sense is something you develop over a period of time, watching for the small things, the subtle things, the history, the clinical examination, a lot of things. So I'll be a little brisk. I have a lot of slides, but the time limit is very less. So I'll be skipping certain things. So if you have any doubts at the end of the talk and after the panel ends, we will take questions, if that's okay with everybody. Thank you so much again. So navigating the complexities in primary care, unipolar versus bipolar depression. So if you look at the whole psychiatry, so how do we differentiate when a client comes to us with a symptomatology which is almost similar across a lot of illnesses, we are at the seas. So the most important differentials are the borderline personality disorder, unipolar depression, ADHD, schizophrenia. But for me, the most toughest is the unipolar depression, not borderline personality disorder. Because if you look at our part of the world, if you look at the Southeast Asia, the personalities are a little less than core psychiatric morbidities. So this is a response from 473 psychiatrist, Journal of Clinical Psychiatry. स्लाइड क्यों नहीं जा रहा यार? So what does the DSM-5 say? If you look at major depressive illness in bipolar 1, 2 and major depressive disorder, it is almost similar. So there's nothing much. Both the presentations as of depression in unipolar and bipolar are similar. So why are we discussing it? MDD and bipolar depression have the same features, at least as per the DSM-5 criteria. Bipolar disorder is under-recognized in clinical practice. Differential diagnosis depends on absence of a hypomanic or a manic episode. So it's most of the time a hypomanic episode is missed. When we talk to a patient, they tell that we had 3 depressive episodes. Then we think that it is unipolar and we start them on an antidepressant, which is absolutely opposite to the treatment which would have taken if the patient was a patient of bipolar depression. So it is very, very important. The delay from appearance of first mood symptoms to correct diagnosis ranges from 7 to 10 years. Can you imagine your mother or your father has a bipolar illness, you go to a psychiatrist and the correct diagnosis comes after 7 to 10 years. By that time, the whole illness characteristic changes, the brain morphology changes, the anatomy, the microanatomy of the brain would have had subtle changes. And then maybe sometimes it's too late. Misdiagnosis leads to inappropriate treatment, functional impairment, and poor quality of life. So for 10 years, if you look at 10 years, you look at 4 episodes, already a person has lost 4 to 5 years of his life. So that's cruel. What is the challenge? High prevalence of depressive symptoms in unipolar vis-a-vis manic hypomanic symptoms in bipolar depression. So if you look at bipolar depression, the prevalence of depressive symptoms is much more than of manic or hypomanic symptoms. High prevalence of threshold manic symptoms in both bipolar depression and unipolar depression, and lack of objective markers, that is blood, imagination. We don't have any thing to tell that, okay, this is the difference between a bipolar and a unipolar. Every other clinician, every other person has something to fall back on. We psychiatrists have nothing to fall back on. And the consequences of a misdiagnosis: delayed introduction of mood stabilizers. Early use of mood stabilizers has better effect. We all know that. Duration of untreated illness, be it psychosis, the more it is, the worse the prognosis for the client is. Patients with more than 3 episodes less likely to benefit from lithium. Lithium is inexpensive, is the best mood stabilizer that is available, and is devoid of a lot of serious metabolic side effects which like other mood stabilizers have, and poor quality of life. Incorrect use of antidepressants in a patient with bipolar. Now, somebody with bipolar comes to you and you give him antidepressants. What does it lead to? It means there is ineffective medication. There's an elevated risk of cycling. Now, somebody from depression goes into a rapid cycling, and sometimes we feel that the depression is worsening. We add another antidepressant, does not work. We put the patient on ECT, patient does not improve. Sometimes, we might lose a patient because of suicide. And risk of a full-blown manic episode. Somebody is depressed, you introduce an antidepressant, not understanding that it is a case of bipolar depression. The patient switches to a full-blown manic episode. And in a full-blown manic episode, somebody might take a lot of risks, might spend a lot of money, do something which might lead to something which cannot be reversed back. And the risk of suicide is always high. Now, Kreplin's rubric of a manic depressive insanity. He told, in the course of years, I have become more and more convinced that all abnormal mood states represent manifestations of a single morbid process. So it all starts from a single process. And if you look at the evolution of the concept, Kraepelin in 1866 talked about manic depressive insanity. Weygand talked about mixed states. Leonard was the man who coined the term bipolar disorders. Dunner talked about bipolar 1 and 2, and it was Akiskel who spoke about the bipolar spectrum from 1 to 6, 1.5, 2.5, 1/4, 3/4, anything you want. So it was Akiskel who gave the concept of the spectrum. So from Kraepelin, we moved on to Akiskel. So now talking about the dimensional versus categorical differentiation. So we look at salient features. So categorical approach talks about considers illness as being either present or absent, no in between. Dementia talks about the whole spectrum. It's a continuum from less ill, normal, less ill to severely ill. And a hybrid approach talks about a combination of categorical and dimensional thing. So in a categorical approach, issues are threshold of diagnosis. When do you make the diagnosis? What to do with subsyndromal symptoms? Somebody is having subsyndromal symptoms. Where do you put it? How should prototypical cases be defined? Delimitation from other disorders and hierarchy of diagnosis is very important. What should come first? But if you look at dimensional approach, can all mental illness be defined on a few dimensions or have different dimensions for each disorder? For a particular disorder, whether to take only one dimension of severity or multiple dimensions. Like if you have 5 categories or 5 dimensions of a illness, do we look at severity in terms of one dimension, or if you group together all the 5 symptomatology into their severity and then talk about severity of the illness as a whole? When to treat, intervene when symptoms are in continuum. So the hybrid approach talks of combining both. So move from a categorical to a dimensional approach. DSM-4 talks about manic, mixed, and depressive. DSM-5 talks about manic with mixed features, depressive with mixed features, and depressive. So this is now we made a spectrum. From a delineation, we have a mixture of symptoms. So DSM-5 has been updated to include a new with mixed features specifier for hypomanic, manic, or depressive episodes. So DSM-5 has upgraded itself. Now the dimensional approach. Core symptoms, if you look at DSM-4, it was manic, mixed, or depressive. DSM-5, again, we talked about manic, where there is elevated mood plus energy. We have manic with mixed features, where elevated mood plus energies, and depression with mixed features, which I was talking about. So, and this you need to understand that time depressed, bipolar 1 versus bipolar 2. So if you look at bipolar 1, the patient is depressed for around 32% of his life. 9% of the time he's manic or hypomanic, and cyclic is only 6%. He remains asymptomatic for around 53%. So 50% of his life of a bipolar 1 is spent being symptomatic, of which majority is in depression. But if you look at bipolar 2, now check yourself. Bipolar 2 is depression with hypomanic episodes. So 47% of the time somebody is asymptomatic and 50% of the time somebody is depressed. So bipolar 2 you have where it is where there are episodes of hypomanic, and most of the times we are unable to elicit that. 50% of the time somebody remains depressed, and that is huge. Now time spent in depressed state greatly exceeds that in manic or hypomanic state, which I showed in the pie diagram. Patients with bipolar disorder 2 spend more time in depressed state as compared to bipolar disorder 1, which I was talking about. This is the diagram. Now coming to the polarity of depression. In patients with bipolar depression, in patients with bipolarity, depression is the predominant polarity. Again, in patients with bipolar, depression is the first polarity. It is the predominant polarity. It is the first polarity. So many times when a patient presents to us as the first episode of depression, we have to think that most of the time we think it is unipolar depression. Until unless there are certain parameters, certain things which makes us think that this might be bipolar. You get the point? But there is nothing that can 100% tell that no, this depression is that of a bipolar depression. This is unipolar depression because it is the first episode. There is no previous episode of a hypomanic episode or a manic episode. Then we have to understand, we have to talk to the client wherever we find that there is a chance of a switch. We need to talk to the client's family, that whenever you feel more energetic, when you have reduced sleep, when he starts talking more, he becomes a little more irritable, please immediately stop the antidepressant and bring it to us. Because many times we cannot justify the start of a mood stabilizer or the start of an antidepressant under the cover of a mood stabilizer. Tomorrow the client will come and tell something to us. Why did you give me this? Why did you give me that molecule? Why did you give me valproate? Why did you give me carbazepine? Anything can happen. So we need to be sure about what we are thinking when we convey the thing to our clients. The unequivocal manic hypomanic episodes, needle in a haystack. Look at bipolar 1, it's only 6%. And if you look at bipolar 2, it's only 2%. So out of 100 days, a man or a woman, if you look at 10 years, 2% of 10 years is only 70 days somebody might be in hypomanic. And the hypomanic episodes are so brief, so subtle, that many of the time patients don't even feel anything because they feel very good. out of a state of remaining in a depressed state, dysthymic state for days, months, for a few days, maybe 10 days, 15 days, they feel a little better. And they attribute it to maybe a marriage in the family, to something good happening in the family. That's why the person is happy. They don't think it is abnormal. They don't think it is something which is not, which cannot be explained, and that it needs to be reported to the doctor. So they don't report it to the doctor, and then we miss out hypomanic episodes. So it's like searching for a needle in a haystack. That's what the whole meaning is. The risk of subsequent diagnosis of bipolar in a patient presenting with a depressive symptoms. If there is family history of bipolar disorder, 50% chance of a depression going into bipolarity. History of symptoms of mania in the, then 34% chance. History of treatment is 8%. But I'll tell you, in my clinical patients, whenever I get a case of treatment-resistant depression, I see that the patient is not improving on 2 to 3 antidepressants. The illness is more than 1.5 years, 2 years, 3 years. I start them on lithium. And most of the treatment resistance just disappears. 8%, and if somebody is having antidepressant related hypomania, so subsequently 8% of those cases go into bipolarity. So this is the inter-rater variability. How reliable is reliable? Major neuro, I think I'll talk later. So this is another interesting, slide. If you go through this, if you look at number of previous depressive episodes in a unipolar, it is generally 2, but if it is generally in a bipolarity, it is around 6 episodes of depression. Age of onset in bipolarity is early. In unipolar depression, it is later on. Family history of bipolarity is high, 25% in bipolarity. Bipolar depression is only 3% in unipolar. Family history of major depressive disorder is 42% in unipolar depression, whereas it is 43% in bipolarity. I have an interesting slide which I'll be discussing later on. Best predictor of achieving an accurate diagnosis of bipolar versus unipolar disorder in new patients with a depressive episode is accurate family history. So if you take an accurate family history, somebody just comes to you with a case of depression. Okay, so you talk about the family history. If you take a proper family history, 30% of chances times you will diagnose somebody's bipolar correctly. If there is corroborating evidence from family, if there is a family member, again 30% chance of you making a correct diagnosis of whether it is a unipolar depression or a bipolar depression. Based on the clinical practice or the presentation, 21 out of 4 you can diagnose correctly as bipolar, even if the present is depression. And 20% chances of making a correct diagnosis from the evidence of early age at onset of the symptoms. I was talking about this slide. Of bipolar is around 25%. Now, as an epidemiological window for diagnosis, so it is generally, if you look at unipolar, it peaks in the 20s. If you look at bipolar, it peaks in the 20s, early onset. If it is peaking in late 30s, it's mostly unipolar. So bipolar is early, unipolar is little late. So again, onset. So average 7.5 years early for bipolar depression. So please put it in your mind. The earlier the age of onset of a depressive episode, the chances of somebody going into bipolarity is higher. Again, based on the age of onset, unipolar depression versus bipolar depression. So if it is early, less than 20, 45% chances of somebody getting bipolar. So as the age increases, the chances of once you are in the 40s, if somebody has a depressive episode, more so it is a unipolar depression. If it is in the 20s, early 20s and early 30s, more so it is a case of bipolar depression. So based on the age of onset, I think you should be clear. Now, age of hospitalization. Again, unipolar versus bipolar. If hospitalization is early for depression, chances of somebody being bipolar is much more. Now, we talked about age. We talked about, age of onset, disease duration is much more in bipolar depression than unipolar depression. Now, duration of disease. If you look at duration of disease, the more the number of episodes, the more chances of somebody being bipolar. That's what the and longer duration of depression is likely to be associated with bipolar depression. That's what I was telling. If somebody is not improving, the normal, if you look at the normal duration of a bipolar illness, it is generally 6 to 9 months. That's the average stage. For a manic episode, it's 4 to 6 months. For a depressive episode, it's 6 to 9 months. So even if you don't treat, somebody is coming with a mild to moderate depression, chances of somebody improving within the next 7 to 8 months is high. But now some come to your hospital, somebody's come to your clinic, and somebody is under your treatment, and the depression is persisting. Somebody is not in your treatment, this depression is persisting. The chances of this being bipolar depression is much higher. Okay. So based on the duration of disease, the, the period of depression is more, the chances of patient being depressed is much more. This is a rule of Akiskal. Clinically depressed patients who exhibited the following behaviors were likely to be diagnosed eventually with bipolar disorder: 3 failed marriages, 3 failed antidepressants, 3 simultaneous jobs, history of 3 personality disorders. I think those are old theories. I just shared it to you. The red sign, this is if somebody uses a red pen, wore a bright red hat, drove to the appointment in a red sports car. That's even a dream for us, driving a red sports car. So refers to depressed patients eventually diagnosed with bipolar 2 disorder. Akiskal summarized that these behaviors were incompatible with a depressed mood state, exhibiting a flamboyant aspect of bipolar 2 disorder. That is a hypomanic. Red pen. Was he wearing better dresses? In India, we asked about wearing more sindoor. Now, this was based on the age of onset, duration of symptoms, and all. Now, differentiation based on symptoms. Now, the patient presents to us. You took a history. Now, you have to also understand the symptoms, the symptomatology with which the patient presents. So, features of depressive episode that are more predictive of bipolar disorder. This is a very, very important slide which I wanted to share. So, if there is early age at onset, which we have discussed, psychotic depression before 25 years of age. Somebody comes at 40, 45 with a psychotic depression, we think of a unipolar. But if somebody comes with a psychotic depression before the age of 25 years, think of a bipolarity, please. Postpartum depression. One of the commonest indicators of bipolarity in a female is postpartum depression, followed by psychotic features. Now, if somebody comes with a postpartum psychosis, please think of adding a mood stabilizer to the client. Rapid onset and offset of depressive episodes of short duration. Now the depressive episode comes and walks away fast. Less than 3 months, think that it might be a bipolar depression. Recurrent depression, which I was talking about, more than 5 episodes. Depression with marked psychomotor retardation. One is a psychotic depression, one is a postpartum depression with psychotic features. Another is a depression with cross psychomotor retardation. Okay, we understand that a depression will have psychomotor slowing, thoughts slow down, actions slow down, words slow down. But when it is psychotic, when it is when it is almost like a catatonia, talk about this. Atypical features, that is reverse vegetable signs. Like what happens in depression? You have rest, sleep, you have less appetite. But what happens with in atypical depression? What happens is the patient's appetite increases. The patient sleeps much more. There is rejection sensitivity. And the patient feels that he's not able to walk because lead pipes are attached to his legs. So we call it as leaden paralysis. Seasonality. Many times we have recurrent depressive disorders which come only in winter, sometimes in summer. Those are the indicators that somebody might be bipolar. And if there is a family history of bipolar, if you understand these things, you will not miss a bipolarity. Now, features, now high density 3-generation pedigrees. There is a lot of bipolarity in your family. There is a trait mode lability. If somebody has a cyclothymia and premorbidly, chances of he being bipolar is much more. There is hyperthymic temperament. There is hypomania associated with the antidepressant. You've given an antidepressant patient as hypomania. Chances of he becoming or she becoming a bipolar is much more. Repeated loss of efficacy of antidepressants after initial response. This is one thing, please mark in your clinical practice. You've started somebody on antidepressant. Patients showed beautiful response in the first 2 or 3 months. Then the response stops. Patient relapses. Then after 1 or 2 months, you change the antidepressant. Again, there is good relapse. So if there is 3 loss of efficacy of antidepressants after initial response, think of a mood stabilizer. I always think of a mood stabilizer after 2 loss of efficacy of depressive mixed states with psychomotor excitement, irritability. There is irritable depression, racing thoughts when somebody is depressed mood, and sexual arousal during major depression. Think of a bipolarity. This is back skill. This is wonderfully described. Symptomatic differentiation. How do you differentiate? Antidepressant treatment causes agitation and anxiety. think of bipolarity. Initially response to antidepressant treatment, then relapses. Family history, again, cycling, severe depressive episodes, deliberate attempts to self-medicate, varying degrees of manic symptoms, onset of MDD before the age of 18, past suicide attempts, mood congruent psychotic symptoms, think of bipolarity. So these are the symptomatic differences. Bipolar depression, there will be history of mania, hypomania, no history of mania or hypomania. Cyclothymia and extroverted, dysthymic. Postpartum episodes are more common, postpartum episodes are less common. Young age, middle age. Psychomotor retardation, psychomotor agitation. But remember, when you start antidepressants and the patient of depression becomes agitated, then it is a chance of bipolar depression. But in the presentation, if there is psychomotor retardation, it is bipolar. If it is psychomotor agitation, it is unipolar. Hypersomnia, which I was talking about, insomnia and unipolar depression, family history of mood present, family history of mood may be present or not present. So these are the most prevalent bipolar prodromal symptoms, from too much energy, ability to think, indecisiveness, talkativeness, insomnia to overproductive and being goal directed. So not important. Cognitive and psychomotor components. Let's look at this. Bipolar depression patients have a higher SRS score, lower MUCA score than UT. So this is the scale. We have the salpeter retardation rating scale, specifically measures psychomotor retardation. So what happens? Bipolar depression patients have higher retardation or psychomotor retardation. But if you look at the Montreal Cognitive Assessment, in the Montreal Cognitive Assessment, the bipolar patients have lower score than the unipolar depression. Okay, but if you look at the intensity and the severity of depression, there is no difference between both the group of patients. But BD patients have a higher SRS score, means they have greater psychomotor retardation and lower cognitive skills. So this is one of the differences. So mixed features, again, how do you manage somebody in cases with mixed features? Major depressive disorder with manic features, traditional antidepressants, SSRI or SNRI, switch antidepressant or augment with atypical antipsychotic. If it is bipolar disorder type features, augment with a mood stabilizer or like lithium or lamotrigine. Transition from MDD to BPD. So substance abuse did not impact the recovery from bipolar depression, and substance use increases the risk of switch to manic, mixed or hypomanic when it comes to unipolar. And if you look at substance use disorder as a comorbidity, it is very, very high in bipolarity. So these are the comorbidities. So 56% of the patients of bipolar depression will have substance abuse as a comorbid diagnosis. So these are the overlapping symptoms of bipolar and substance abuse. So symptoms of unipolar and bipolar depression have huge overlap, often leading to misdiagnosis, negative consequences. Demographic factors may play a significant role, offering epidemiological windows for a differential diagnosis. Example, younger age at onset often points towards bipolar. Family history may indicate more towards unipolar over a bipolar diagnosis. Clinicians should remain alert towards symptom constellations and comorbidities, which can put them in a stronger position to make a differential diagnosis. Thank you so much for your patient hearing.
Thank you, sir. Thank you for taking us through this differential diagnosis of bipolar and unipolar. And I think the audience got a lot of practice pearls in terms of differentiating on the basis of presentation, symptoms, and whatnot. Let me now turn over the presentation to Dr. Ruwana Priya. Sir, request you to please come in and share your reactions to this presentation as well as your perspectives based on your practice in Sri Lanka.
Yes, thank you, Professor Amrit, for giving us a very detailed description about differentiating unipolar and bipolar depression. And I think, as he correctly said, bipolar depression and the unipolar depression is the most the differentiating and treating, especially the bipolar depression is the most one of the most difficult illnesses we come come across in our mental health practice. So, Professor Amrit shared a lot of theoretical and historical facts and a lot of new thinking. So I suppose I don't have much to say with regard to how to differentiate and those things. So from my clinical experience and from Sri Lankan point of view, so we also have the same issues, like there are a lot of misdiagnosis, mainly due to some of the patients are being managed as depression, and some of these patients are being functionally impaired for long duration with long duration of psychomotor retardation, and also resistant symptoms which has not been addressed properly, and also some patients who are on treatment, maybe 1 or 2 antidepressants or several other medications, still continue to have fluctuating symptoms and significant functional impairment. So those are the things we also see in Sri Lankan practice. And also, if we talk about the treatment options, as we know that it is a bit difficult. Managing bipolar depression is, I think, one of the most difficult illness. So with all these new evidence, treatment evidence and guidelines, we know that we are using some kind of combination of medications, right? So in Sri Lanka, I think the freely available in both state and private sector, we use this olanzapine and fluoxetine combination, which is very effective, and which is I also personally use that combination, which is also freely available and affordable to our patients. And also the combinations of olanzapine lithium plus lamotrigine, and also quetiapine plus SSRI, or quetiapine plus lithium, right? Those are the combinations we use in Sri Lanka most commonly to treat bipolar depression. And the problem is in our clinical setup, we know that we don't have human resources. We are running with poor human resources, limited number of psychiatrists and other mental health professionals. So the problem with the follow-up. So there are a lot of defaulting treatments, dropouts, and those things, those are the main challenges. And other things are the affordability, right? So many of our patients, they can't afford some hi-fi medications or the new medications because they are not available in state sector. Right. So, and as Professor Amrit said, ECT is one of the most commonly used and most effective method of treatment for bipolar depression in Sri Lanka. So, in many of our hospitals, general hospitals, we have ECT facility. So, many of our consultants and I myself, we have much more high priority to start ECT in patients presenting with bipolar, and we have seen a lot of good effective outcome, right? Significant improvement of functional level, significant improvement of psychomotor retardation, and significant improvement of treatment resistance. And I have seen using ketamine as well. So we know that ketamine has been used to treat unipolar depression, especially the resistant depression, or patients with patients who have sub-threshold symptomatic control, like that. So I have seen using ketamine in bipolar depression as well, with some good evidences, but I'm not sure whether it is yet to be like approved in some centers, right? So I think in some centers it is in research level. And as I said, in Sri Lanka, in our practices, we try to use evidence-based methods, including pharmacological treatment and ECT. As I earlier mentioned, commonly we use the available medication combinations. So we don't have these hi-fi antipsychotics which are using in other Western countries. And as Professor Amrit said, due to lack of good history taking, lack of inquiring about family history and the symptom duration and other other things like treatment resistance and compliance and these things, a lot of our patients who are supposed to be on treatment for bipolar depression are on treatment for unipolar depression. So I think from today onwards, with his insights about how to differentiate these things, we will be able to focus more on differentiating these things and treating some of our patients who are treating as unipolar depression. I think we will be able to do that. And yeah, so those are my thoughts about today this topic. And so I thank again Professor Amrit for sharing very good insights about this bipolar and unipolar depression and clinical problems we come across day-to-day our practice. So yeah.
Thank you, Dr. Rohan Priya, for your comments. And Professor Pattajoshi, if you permit, we have some questions from the audience. We can take, in the interest of time, maybe a couple of questions. Yeah. Sir, so just a quick question is, you briefly referred to use of lithium in patients with treatment-resistant depression.
Yes.
Yeah. So how do you decide when to switch a patient to lithium or when to add lithium to their existing therapy?
No, that's a very, again, that's the sixth sense that comes with experience. When, I always tell people that there is no resistance. People talk about treatment resistance. I told there is a resistance in the mind of the clinicians on how they treat. If you choose the right patients, if you understand, I'll just talk about psychosis. If you look at schizophrenia, now clozapine is something which we use with a lot of apprehension. We use it maybe 2 to 3 years later, but the ability to understand the symptom profile where you want to intervene with clozapine as a first line, because I want my client to be stable and good as soon as possible. Sometimes the delay might lead to a death. The delay might lead to a homicide. The delay might lead to something which we cannot retrieve back in life. So the ability of a clinician to understand the nuances inside the patient to intervene is very important. Now, when do I choose lithium? Again, my patient presents to us as a first episode depression. And I talked about, I was trying to reiterate 10 points. In my 30 minutes, I have talked about 10 or 8 points 10 times. If you must have realized that. But those are the 8 to 10 things you need to put it in your algorithm that yes, duck, when a client names, I need to understand the bipolarity, age of onset, was there any hypomanic episode, what is the temperament, was response to treatment now. I am a lot of clients come to me after they've gone and seen people. It's not that they just come to me first time. So you need to understand how has been their response to antidepressants. What is the duration of the illness that is going on? Because if you look at the natural course of illness, at 6 to 8 months, the patient should improve. Now, somebody is being treated on an antidepressant. And again, if you look at textbooks, every antidepressant has this similar efficacy. It is 66%. Out of every 3 patients clients you treat with any XYZ, a ninth class person, even if I tell him talk about acetaldehyde, if you give a patient, he will have 6 patients out of 10 who have recovered. And 1 or 2 will recover without treatment. It is the 1 or 2 out of 10 that we need to understand which molecule we should give, which molecule works. So if there is a duration or there is somebody who's not responding to antidepressants, there is cycling, there is irritability, subsyndromal symptoms are always beginning. Patient is never felt good. Patient has never felt that he has come. That is not unipolar. That is bipolarity now. Now you need to understand this and give a lithium to it. And I think lithium is the best agent. If I talk about a mood stabilizer, I might not consider it. But if you look at treatment-resistant depression, if you look at bipolar depression, if you look at bipolar 2, lithium, there is nothing that beats lithium. And most of the cases, and sometimes treating a bipolar is much more tougher than treating a schizophrenia. But schizophrenia is very simple. There's some which might not improve, but if you look at bipolarity, the way you look at it, the perception of yours towards your patient helps in the recovery of the patient. And that's where the acumen of the clinician is very important. That's my take on it. People might not agree to my line of thinking.
Another very specific question for you coming from Dr. DJP Herath from Sri Lanka is he wants you to elaborate a little bit on management of mixed episodes.
Yeah, like mixed management. Now if you look at mixed, do we have a depressive person who is psychomotrically retarded, feels down, but he has racing thoughts? Or we have somebody who is hyperactive, who is talking more, but the theme is depression. He talks about negativity. You need to understand it. Is it core this or core? Based on that, you need to intervene.
Yeah.
So my concept is, if it is mixed, you need to, if you think that, yes, patient is suicidal, patient might end his life, patient is absolutely need to get the switch on also. So be little low on the mood stabilizer, little high on the antidepressant.
Okay.
Right? If the core features are manic and the theme is a little down, you add little bit of antidepressants with a core of more of mood stabilizer control. So that's a subtle art now. You need to work on it with time and patience.
I think most of the senior psychiatrists in the audience will agree that managing patients is more of an art, less of a science. Of course, the science remains. One more questions from Dr. Maria Evangelista from the Philippines. Now, she has presented a case, is a teen presenting with depressive symptoms but unclear family history. In such a patient, would you recommend a mood stabilizer immediately with or without an antidepressants? And if yes, which mood stabilizer would would be better for a faster response and safe as well?
Now, the choice of any drug depends on the side effects which you want in the client and the side effects which you don't want in the client. When we choose an antidepressant, I always feel that you need to use the antidepressant side effects or the molecule side effects to our best interest of a client. So if somebody is not eating, somebody has reduced significantly, think of a mirtazapine. If you think there is a lot of psychomotor, agitation, just think before you add a fluoxetine, because the best drug for a child is fluoxetine. That's in my clinical practice talks about fluoxetine. Now there are little, if there are a lot of anxiety symptoms and the blood pressure and all is good, think about a venlafaxine or a desvenlafaxine. If you think like there are a lot of somatic symptoms, in our part of the world, we get a lot of somatic symptoms, maybe headache, maybe stomach ache. Think of a TCA. Based on symptomatology, you think of what to add. And now, but you have to be very, very clear. If there is a psychotic depression that is presenting very early age, the age of onset is very early. It is grossly psychotic. Patient, we are not very clear about the family history, but we need to talk about the temperament. We might not get the personality, but the temperament, how the patient has been, is he irritable? Is he having ADHD symptoms? Nothing of a bipolarity. And then we need to not think of a mood stabilizer in the present scenario, but to be ready with the mood stabilizer the moment the patient switches or patient shows any overt sign of a bipolar illness, maybe a hypomanic episode or a clear-cut manic episode. So we need to talk to the client, we need to talk to the relatives, we need to discuss with them what will happen if something like this happens. And they can immediately, 2 nights the client did not sleep, he seems more energetic, please bring it back to us. That's how we discuss.
So in the interest of time, I'll take just one last question and I'll pose it to Dr. Ruwanapriya. Sir, considering bipolar in women of childbearing potential, such patients, what would be the best drug to choose? This is a question coming from Dr. Upali Pieratna from Sri Lanka.
Okay. So, so childbearing age or the young females who we as a principle, we don't use sodium valproate as a mood stabilizer for women because it can cause significant severe congenital malformations if these patients get pregnant, right? So, but with the new evidence, initially in the past, we were a bit hesitant to use lithium. But with the new evidence, it has been said that lithium is safer, right? Lithium also has some congenital malformations, but the relatively incidence is less, right, compared to what we thought in the past. So lithium is a good choice if you are treating a young woman or woman with a childbearing age as a mood stabilizer. I think the lithium is the best one, right? And also you can use carbamazepine, right? Try to avoid sodium valproate. If you are using sodium valproate, you need to educate the patient regarding appropriate contraceptive methods or postponing the pregnancy. And whenever they want to get pregnant, they should come to us, come to the clinician, the psychiatrist, and discuss. And then the psychiatrist need to tail off the sodium valproate and put the patient is on appropriate mood stabilizer. So lithium also, if patient is having anxious thoughts about lithium while using lithium getting pregnant, so we can even discuss with the patient, right? If patient does not prefer to use lithium during the pregnancy or the before getting conceived, so we can stop lithium and we can start a second generation antipsychotic which has some mood stabilization property like olanzapine, risperidone, or quetiapine, right? So that is a one choice that we can use. But if patient is willing to continue with lithium, we can continue with lithium while monitoring the patient, and at the second trimester, we can advise patient to get anomaly scan, and most of these congenital anomalies which happen with lithium is correctable, right? Those are the cardiac malformation, most of them are correctable, right? So we can take appropriate actions. Yeah, so and during the breastfeeding also, we can't continue lithium because lithium can excrete in breast milk. So we can change into sodium valproate or carbamazepine, right? Or we can use olanzapine or other similar second generation antipsychotic as a mood stabilizer, right? So that is the practice we commonly do, right? I think I answered the question, right?
Yeah, thank you, sir. So, so with this,
There's one. If I can add one line,
sure,
I
sir.
can add one
Please,
line.
please go ahead. Yeah.
If you look at evidence as an anti-epileptic, best for pregnancy is also oxcarbazepine, sir. If you look at evidence, so oxcarbazepine, because once you talk of lithium, whatever the evidence, people will talk about the anomalies. I've seen
Yeah.
even doctors being afraid of lithium. The moment they see lithium, but the gynecologists just jump from their seat as if we have given them cyanide. That's the reactions I get from people. So many times the whole narrative is created by doctors around us. It's not the patients who create the narratives. It's the gynecologist and these are the people who create the narratives. And you can also add a oxcarbazepine, which is very, very good in terms of evidence, and did not switch from one to another, because we do the best, we tell the best, but the doctors around us create a lot of noise nuisance. I think That's the only line I wanted to add. Thank you, sir.
Very, very interesting, sir. Thank you. I think this was a very rich discussion. And to conclude the session today, let me invite my counterpart, Mr. Hardik Shah, who is our global brand manager for CNS therapy, to deliver the vote of thanks. Over to you, Hardik.
Yeah. Thanks, Dr. Hardik. So, today's session has been really a remarkable conversation of knowledge, experience, and shared commitment to advancing our understanding of differential diagnosis, so unipolar versus bipolar depression. So, on behalf of Zydus Life Sciences, I would like to extend our deepest gratitude to our esteemed speaker, Dr. Amrut Patajoshi, sir. Your comprehensive presentation on the latest advancement in diagnosing unipolar and bipolar depression was not only enlightening us, but also provided us with a deeper understanding of the complexities involved in diagnosing and treating this condition. And I would also like to express our heartfelt thanks to our panelist, Dr. Samira Ruwanpriya. Your insightful contributions during the discussion have added immense value to this session. And finally, I would also like to acknowledge the audience for your active participation and engagement. So thank you all once again for your participation and contributions. Have a wonderful day ahead. Thank you all.
Come.
Thank you, sir. Thank you very much.
Thank you all.
Thank you, sir.
मिलते हैं कोलंबो में समीरा, डॉक्टर समीरा.
Yes, yes. So we'll meet next week.
Yeah, we'll meet next week.
Okay.
Thank you, sir.
Bye.
Bye-bye. Bye-bye. Have a nice day.
Bye.
हार्दिक भाई ठीक ठाक था?
Yes, sir.
हाँ?
Yes, sir. Yes, sir.
Okay.
It was nice. We have a very inquisitive audience always, so we had some more questions, but in the interest of time, maybe probably next time we'll have more time for discussion.
But ठीक था तो presentation was okay, था?
Absolutely, absolutely, sir. Wonderful presentation. Looking forward to meet you in person soon, sir.
Yeah.
Yeah.
These are things that need to be discussed. These are very